Good morning, everyone. My name is Stephanie Romano, and I'm the Education Coordinator with today's hospital program. Thank you for joining us again for another SWORBHP webinar. Today we're talking about capnography. Might have been a while since we've had a little lesson on capnography, so we thought a review might be useful. If you are new to webinars with SWORBHP, what you're going to see in front of you is a PowerPoint presentation. You're going to hear some presenters talking over the PowerPoint. We do have a number of poll questions throughout this presentation, so do stay active and make sure you answer those poll questions. We will introduce them and we'll talk about the poll questions when they do come up. If you have any questions throughout the presentation, feel free to use the question box. So you'll see in your toolbar there's a question box or a chat box that you can use to type questions to me throughout the webinar. If you do have a microphone and you want to ask a question live, we're going to leave those to the end of the presentation and then we'll open up the floor to those at the end. So once again, your questions throughout, do type them to us. We will answer those. Otherwise, we'll open up the floor to microphone live questions at the end. And so without further ado, I will hand the presentation over to Dr. Matt Davis, our local medical director in charge of education here at SWORBHP, and Christine Hardie, one of our regional paramedic educators.
Okay, thank you, Steph. Let's just go over some learning objectives of today's webinar. So we're going to recall the physiology of ventilation, recognize the benefits of capnography, identify the role of EndTidal CO2 monitoring in the pre-hospital setting, and hopefully at the end of the webinar and getting back into the field, we'll be able to integrate capnography into our current practice. So the first thing we want to do is review some of the pulmonary anatomy and physiology. The primary function of the respiratory system, as we know, is to exchange carbon dioxide with oxygen. And during inspiration of air, it enters the upper airway where it's warmed and humidified. It flows through the trachea and the bronchial tree to the pulmonary alveoli and eventually diffuses across the capillary membrane into the blood. The heart pumps all of this freshly oxygenated blood throughout the body to the cells where it's metabolically consumed, and the carbon dioxide that's produced eventually is pumped back through the body and eventually expelled or exhaled through the mouth. Very quickly, we'd like to clarify what the difference is between oxygenation and ventilation. Oxygenation is actually how we get oxygen to our tissues. We inhale it, it goes to the lungs, and eventually is transported into our tissues through the bloodstream. At the cellular level, oxygen and glucose combine to produce energy, and that is how we end up with carbon dioxide as the byproduct. This process is the Krebs cycle, which Matt will explain in detail.
Absolutely. I'm going to explain every little step here in detail to make everyone very interested in cellular metabolism. So, I mean, this is very simple. We all learned it in grade 11 biology in high school, so probably everyone already knows every step of this and can draw the Krebs cycle by memory. All joking aside, at the end of the day, what the Krebs cycle comes down to is your body needs energy, so it takes fuel. That fuel is metabolized into ATP, which is energy, and you have your waste product at the end of the day, which is carbon dioxide.
Thanks, Matt. So to be very clear, let's differentiate between pulse oximetry and EndTidal CO2 before we go much further. Pulse oximetry is what provides us with our instantaneous feedback about the oxygenation in the body, whereas an EndTidal CO2 is telling us how effectively carbon dioxide is being produced and eliminated from the body. We're going to briefly touch on the ventilation-perfusion relationship. It does have a bit of relevance, and as we go through the remainder of the webinar, it will become more clear how that applies to EndTidal CO2 monitoring. But we're going to keep it really basic right now. We just want to point out that when the body is functioning normally, if we have a ventilation or perfusion problem or it's unstable, a mismatch can occur, which results in inadequate oxygenation and altered partial pressures of carbon dioxide. This is when the ventilation-perfusion relationship comes into play. The VQ relationship refers to the relationship between the amount of air that's getting into the lungs and the amount of blood that is being sent to the lungs. This ratio is important because it's a major factor which affects the alveolar and arterial levels of oxygen and carbon dioxide. And again, what we're focusing on today is the carbon dioxide purpose of this. For our purposes, we're going to revisit this later, but we're going to only discuss the VQ relationship in terms of whether it's high or low. And again, we'll touch on this again.
So in terms of kind of nomenclature for this presentation, a few terms that you need to be familiar with. The PaO2, which refers to the partial pressure of oxygen in an arterial gas sample. And in a normal, non-sick individual, this usually runs between 85 and 100 millimeters of mercury. The partial pressure of carbon dioxide, when measured in the same blood sample, usually runs between 35 and 45 millimeters of mercury. So that's in a normal, healthy individual. The difference when you look at your EndTidal CO2 to your EndTidal partial pressure of CO2, so that's looking at the concentration of carbon dioxide in your exhaled air versus that remains behind in your blood. When looking at EndTidal measurement, the difference between these two values is roughly between 2 to 5 millimeters of mercury. And again, that's simply in a healthy individual. So someone who doesn't have a disease process going on, they correlate relatively well, but as soon as a disease process occurs, your EndTidal CO2 and your concentration of carbon dioxide within the blood isn't always precise, and that's where you tend to have to look at trends over time.
Okay, so our purpose is we want to attempt to maintain a partial or an EndTidal CO2 reading of approximately 35 to 45 millimeters of mercury. And just to reiterate what Matt just said, so if we have a change in the ventilation-perfusion relationship, this is what will alter the relationship between the arterial CO2 measurement and our EndTidal CO2 measurement. So keep that in the back of your mind as we progress through the webinar. So getting to what exactly capnography is, it's the measurement of the exhaled carbon dioxide. It's displayed as a number in millimeters of mercury or as a percent. You're going to be recognizing this on your cardiac monitors through your services. It provides us, the paramedics, with a waveform as well, which tracks the exhaled carbon dioxide over time. We call this waveform a capnogram, and you can see an example of a normal capnogram at the bottom of the screen. So again, the EndTidal carbon dioxide is the partial pressure of carbon dioxide at the end of an exhaled breath as measured and displayed on your cardiac monitor. Indirectly, capnography will measure the metabolism and circulation and the use of and production of carbon dioxide in your body. So for an example, an increased metabolism could increase the production of carbon dioxide, increasing someone's EndTidal CO2. An example is if we had a decreased cardiac output or decreased perfusion status, that would lower the delivery of carbon dioxide. That eventually gets to the lungs, and we would see a decrease in EndTidal CO2 monitoring levels on our cardiac monitor. So hey Matt, how do you make a slow reindeer fast?
I don't know if I want any part of this joke right now. I have no idea.
You stop feeding him.
Brutal. Wow, technology at its best.
That's pretty good.
So with that, I think we're going to start some poll questions. So I'm going to launch our first poll question here, and just make sure that we're all on track with our learning. And we do have 3 poll questions in a row, so we'll stop after each one to discuss the answer. So the first poll question is up. The question is, how is oxygen converted to carbon dioxide in the body? So option A is oxygen is used by the body and the byproduct is CO2. Option B, oxygen is converted to carbon dioxide in the lungs after alveoli saturation. Option C, alveoli converts oxygen to carbon dioxide according to cell needs. And option D, pressure in the bloodstream converts oxygen to carbon dioxide. So we've got about half the audience that have voted, so we'll give you a couple more seconds to answer. All right, so I'm going to close the poll. It looks like we have about 90% of the audience answered option A. Oxygen is used by the body, and the byproduct is carbon dioxide.
Okay, thank you, Steph. We can't actually see the question on here, but that is correct. Do we have another question?
So well done on that one, guys. So the next question is coming up. So the question is, what assessment is best for evaluating ventilation status? And your options are A, EndTidal carbon dioxide, B, oxygen saturation, C, heart rate, or D, respiratory rate. I'll give you a few more seconds to answer that one, and then I'll share the results. All right, so we're sitting at 70% answered option A, EndTidal carbon dioxide.
That answer is correct. So remember, ventilation is how effectively is carbon dioxide being eliminated from the body, and that's where your capnography comes in. It's measuring the elimination of carbon dioxide over time.
Perfect. And then the third poll question should be up now. So the question is, what is a normal EndTidal CO2 reading? So option A is 35 to 45 millimeters of mercury. Option B, 35 to 45 centimeters of water. Option C, 95 to 100 millimeters of mercury. Or option D, 95 to 100 centimeters of water. All right, and we are looking at 93% saying option A, 35 to 45 millimeters of mercury. Well done, guys.
Yeah, that's correct. So the numbers between 35 and 45, and the unit that we're measuring is millimeters of mercury.
Good. So let's look at some of the pre-hospital clinical applications for EndTidal CO2 monitoring. There are very many, as you can see: advanced airway management during pain management, some suspected pulmonary embolism. Unfortunately, we won't be able to touch on every single one of these clinical applications today, but we will certainly touch on a few. And if you have any questions, again, you can submit them via the webinar.
That's right. There's many uses for capnography in the pre-hospital setting, but as Christine states, in terms of that would be more of an advanced webinar when we go in and explain how it can be used in all these settings. It's important to remember that capnography is just a piece of the puzzle, so it's not going to give you your diagnosis whatsoever. In fact, a lot of the times with these other things going on that we could get into more depth about, there's so many little variables that it's not the most specific or sensitive test for diagnosing these illnesses. So again, just remember that capnography is a piece of the puzzle that you use with your history, your physical, your other vital signs, your clinical assessments to determine what is going on and how your treatments are affecting the patient.
Before digging any deeper into the specific conditions, we should look at the types of devices that may be available to you at your service. There's two different types that you'll typically see at your service. One is mainstream capnography, and it's placed directly at the airway of an intubated patient and allows the inspired and expiratory gas to pass directly through the infrared light path that goes directly to your cardiac monitor and will provide you a readout, again with the capnogram and an EndTidal CO2 reading in the form of a number. This is the device that you would put on an EndTidal or on an endotracheal tube. Side stream is located more directly away from the airway, requires the sample to be aspirated and then eventually transported to a sensor. So there's two different types of those. One is the one you see on the left-hand side, looks similar to a nasal prong. Those are used for spontaneously breathing patients. And the other type is the one that most services likely carry, similar to a medication adapter in that it would attach between an endotracheal tube and a BVM, or a King LT airway and the BVM. So we would attach these on if we desired to have EndTidal CO2 readings.
So for all the physicists who have joined in today's webinar, just kind of in brief in general, how this works is the device will shine infrared light into the air sample, and carbon dioxide will absorb that light at a specific wavelength, and based on that it is able to calculate how much CO2 is present in the sample. So that is a very simplified way of looking at it.
Perfect. Let's take a look at the anatomy of the CO2 waveform itself. Notice that it's plotted in carbon dioxide in millimeters of mercury over time in seconds. We're going to start by looking at phase 1, which is circled in red on your screen, of the exhalation phase. There's no expired carbon dioxide in this portion. It consists of dead space gases, and the EndTidal CO2 monitoring reading is 0 at this time.
And just a reminder, your dead space is the air that kind of sits in the mouth, the trachea, where no gas exchange occurs. So that's what's known as dead space ventilation.
In the second phase, now circled in blue, is the ascending expiratory phase, when the EndTidal CO2 increases rapidly. This is occurring when when carbon dioxide is expelled from the alveoli, and those gases replace the dead space gases, so we start to see a rise in the EndTidal CO2 level. Phase 3 is circled in a yellow-green color, and this is the alveolar plateau phase. Notice as you're looking at the circled area, it has a slightly increased slope. It's because this includes late emptying of the alveoli with a lower VQ ratio. It's low because in normal lungs, the lower parts of the lungs are generally better perfused than ventilated and contain higher levels of carbon dioxide. So let's stop there for a second and investigate that just a little bit further and what that exactly means. So as we said in the previous slide, the alveolar plateau phase displays a slightly increased slope over time. You can see the red arrow at the top of the screen there illustrating that. Again, this is because the lower part of the lungs are relatively more perfused than ventilated, resulting in a high VQ ratio at the top of the lungs, meaning, low VQ ratio and a high end CO2 level. The top portion of the lungs are lesser perfused, and the evolution of the gases that are being expired from the alveoli are going to increase over time because the lower portion of the lung is better perfused in normal section of lungs.
So just simplifying that, the bottom portion of the lungs, or the dependent portion of the lungs, better blood flow. That blood's able to dump its CO2 from metabolism, versus the upper part of the airway, which has less blood flow, so less CO2 traveling there, but better airflow in the top portions. That's why you get your differences in your VQ.
So very quickly, if we were talking about a couple of conditions that may, or a condition that may increase the carbon dioxide levels, if we were looking at someone who was suffering a narcotic overdose, as they begin to hypoventilate, they may have changes in their EndTidal CO2. We can also look at a patient who's experiencing bronchoconstriction and subsequently treated with salbutamol. We would see changes in this area of the plateau. So getting back to the actual waveform itself, after that plateau, we see the section circled in orange, and that's phase 4. It represents when the inspiratory section, or when we're starting to breathe in again. What's important for us is the start area. This is point D, we'll call it, and this is the reading that you're going to be seeing on your screen. So this is the maximum, or the maximum EndTidal carbon dioxide expired on any given breath. So this is, you'll see that number displayed, which we want to be between 35 and 45 millimeters of mercury.
So right, the reading is just a point in time reading, so that's why you don't see that number fluctuating with the ventilatory cycle. So your monitors will just read that point D in time and give the quantitative number at that point.
So speaking to some of the clinical applications, the first one we thought was important to put on the slide is the use of end-tidal carbon dioxide monitoring with advanced airway. This comes directly from the American Heart Association guidelines, and it is definitely recommended or should occur that end-tidal cardiac monitor or end-tidal CO2 monitoring should occur in any patient who receives endotracheal intubation. And this is because a couple of studies have discovered that patients who are intubated using end-tidal CO2 monitoring, we can directly notice whether the tracheal tube is in the esophagus and actually confirm that we're ventilating the patient properly with 100% sensitivity and specificity. So that's the first application we want to talk about. It should be used in an end-tidal CO2 or with a King LT as well. It hasn't been studied or confirmed, but the wording and the direct wording they use is that effective ventilation through a supraglottic airway device should result in a capnographic waveform during CPR and with a ROSC. Okay. So this picture here on your screen is an example again of a normal end-tidal CO2 reading at the top. This is what you would desire to see if you had intubated someone or say used the King LT and you were using an end-tidal CO2 monitor. At the bottom, we see an end-tidal CO2 reading that isn't going so well. This could be in the case of when a tube was displaced. So let's say we've intubated a patient and moved them up a set of stairs, and we ended up seeing the bottom waveform. We could assume at this time that possibly the tube has slipped out of the trachea and is no longer ventilating the patient properly. It's important to recognize how significant this can aid us in confirming and maintaining our tube, because if we were using SpO2 monitoring alone, that takes quite a while for our numbers to fall, or oxygen saturation percents to fall. Whereas an end-tidal CO2 monitor would tell us within seconds that the patient is, or we are no longer getting end-tidal carbon dioxide reading levels and we're not ventilating properly.
So yeah, in terms of knowing that the tube's in the right place, this is probably your best indicator that you have a tracheal intubation. Again, when you're confirming the tube placement, you go through various steps to ensure that that tube's in the right place. And the reason why you need to confirm it in so many different levels is because none of those indicators by themselves tells you whether or not that tube is in the right place. So despite seeing misting in the tube, you can still get an esophageal intubation and get condensation in the tube. And I think the literature reports up to 80% of that can occur. So again, even listening, when they've done studies in control settings, so an operating room setting, where the anesthetist intubates the patient, and they either do it in this study, they either did a purposeful esophageal intubation, and they have the anesthetist listen. Up to 20% of anesthetists listening to the chest will say that the tube is in the trachea despite it being in the esophagus. So again, the more time we use these multiple indicators that the tube's in the right place, then the higher chance we know for sure that it's in the right place. And of all the indicators out there, end-tidal CO2 monitoring is the best indicator for proper tube placement. And then looking at your calometric, so when you hook up your calometric capnography to or CO2 detector to the tube itself, again, even that in the certain patients isn't the best indicator that the tube's in the right place. So that's a qualitative measure. That's saying, is there CO2 present, yes or no? Whereas end-tidal CO2 is a quantitative, it's telling you how much CO2 is present in that sample.
That's the one with using litmus paper.
Litmus paper, yeah. So that's based on a pH reaction. So that's a litmus paper. The CO2 hits that paper, and it's above a certain level. That paper will turn purple if it's in the correct place.
Okay. The second clinical application that we'd like to quickly discuss is the use of EndTidal CO2 monitoring with CPR. So if you look at the screen, you can see, and they've detailed, when CPR is started, we've got rescue retiring, and rescue replaced. So what some studies have shown that if our EndTidal CO2 monitoring level is less than 10 millimeters of mercury, that we can consider that it's possible that we need to improve our CPR quality by optimizing our chest compression. So i.e. that a rescuer is tiring. So you can see as they replaced the rescuer, the EndTidal CO2 went up. So that's just one way to maybe notice if we need to replace our rescuers. Another thing we can utilize is may indicate, serve as an indicator for ROSC. So some studies have shown that by observing an abrupt sustained increase in an EndTidal CO2, that it's indicative of when a patient has had a return of spontaneous circulation.
Again, important to remember that this is just a piece of the puzzle, so this alone is not going to tell you 100% of the time if these things are occurring. So, looking at if someone's tiring out with CPR, well, just observing them, watching their quality of depth and the rate that they're going is an indicator that they may be tiring. Use it in combination with your EndTidal CO2 to confirm that, yep, this rescuer is tiring. It's time to switch the person doing CPR. In terms of an indicator of ROSC, what's happening is you're getting a cardiac output with ROSC, and this may be the earliest indicator that you're getting cardiac output because suddenly the heart is able to pump more efficiently than it is alone with CPR, and you get that dumping of CO2 into the alveoli. Again, just a piece of the puzzle. You're going to be looking at other factors as well when it comes to ROSC.
So this doesn't actually change the care of our patient. As Matt said, it's a piece of the puzzle. So for example, if we saw a prolonged, sustained increase in the EndTidal CO2 and we're seeing some electrical activity occur on our cardiac monitor, we may anticipate that we could palpate a pulse, for example.
Absolutely. And again, all these studies have been done in intubated patients, so there's no evidence out there whether or not, just BVM or using a King LT, if the same holds true. In theory, it sounds like it would hold true, but again, the literature or the evidence out there is it's not out there. And again, one thing you want to do with research is be very careful about generalizability. So just because it works in one patient population doesn't always mean it's going to work in the other patient population. So at this time, there isn't the evidence out there for patients who are getting bagged versus King LT. This evidence only exists with those who are intubated.
Right. And I guess the same would hold true that if we had an intubated patient and we had a sudden drop in EndTidal CO2, that we could consider loss of spontaneous circulation or loss of pulse.
Absolutely. So if you see that sudden decline, again, it's a piece of the puzzle. The other things you think, well, if it's a flat tracing, is the tube misplaced? So again, you're going to be taking this as a piece of the puzzle as to what's going on in the situation.
This is an interesting trend. You'll notice in the top that we have an EndTidal carbon dioxide level trending. So this is, again, over time, and you can see that we have periods of ROSC. So this was just an example of a trend over time in a patient who had periods of ROSC, periods of loss of spontaneous circulation subsequently, and then each time their EndTidal CO2 went up.
And you can see those sudden jumps where, you see it trending upward, probably good CPR, and then suddenly it jumps quite high, and again, that would be an indicator of potential ROSC in these patients where you see that large jump between, roughly on this scale, it looks about from 25 all up to almost 50 between the two readings there, if you look at the middle one in particular.
The bottom waveform is just an example of the EndTidal CO2 monitoring that can be, or levels that can be achieved with CPR alone. The long flat line and the subsequent kind of other capnogram is when the patient was intubated. But the first portion of the bottom strip is EndTidal CO2 levels that are produced just with CPR alone initially on patient contact, VSA patient contact. The other interesting thing is that some studies have shown that EndTidal CO2 increases or decreases can actually determine the difference in the type of cardiac arrest you're facing. For example, an asphyxial arrest versus a primary cardiac arrest. One study showed that an asphyxial arrest will have a very high initial EndTidal CO2 level as opposed to a primary cardiac arrest wouldn't, which kind of makes sense. It doesn't change our care at all, but just interesting.
And again, that would be in the immediate witness cardiac arrest. So someone who's choking in front of you has a pulse and then suddenly loses their pulse. You would see these high EndTidal CO2 readings. The reason being the heart is working fine, so this is not a cardiac issue. So the cells are still doing their metabolic function. They're producing CO2, delivering it to the heart. The heart's pumping and trying to get it to the alveoli to gas exchange with oxygen, except now you've got an issue with ventilation, so that oxygen can't get in and that carbon dioxide can't get out, so therefore you have your high reading of EndTidal CO2 with anything that is getting out, versus your cardiac arrest situation where the pump's not working, so it's not delivering that cardiac or carbon dioxide to the lungs, therefore you get the lower readings. Again, these would be in someone who's witnessed. Oftentimes, you know, by the time EMS gets on scene, it's going to be a totally different picture when it comes to your EndTidal CO2 monitoring, despite the etiology of it. So don't use that alone to say, oh, this is purely a hypoxic arrest versus this is a MI arrest.
So while you're watching this webinar and listening to us, you're probably thinking, well, there's a lot of studies saying a lot of different things. Well, at the end of the day, this is something that is fairly new in the pre-hospital setting, been used forever in operating rooms. So there hasn't been a lot of research to support the evidence that's showing in pre-hospital care. But what we're presenting to you is some of the up-and-coming examples of ways that it may be applicable.
So I do have a poll question before we head into the next slide.
Thank you.
And I apologize, it sounds like there might be a little bit of feedback when I speak, so hopefully that is now fixed, but if not, let me know, guys. So the next poll question is up. Just want to make sure we're all on the same page here. So the poll question is, an EndTidal CO2 waveform provides information about the amount of expired CO2, option A, in millimeters of mercury over time, option B, in centimeters of water over time, option C as a numeric value, or option D as a percentage. And it looks like we're sitting 82% answering option A in millimeters of mercury over time.
Did you say 82%?
Correct.
I think that's a repeat of the question. We already had that question. Do you have another one? I was hoping we'd have 100 because we already asked that question.
It was a similar question.
Yeah.
The actual last question was looking at the actual level, so 35 to 45 millimeters of mercury. This is asking over time, and 82%.
Well, then that's good.
So it's a new question, yeah.
100%?
Similar, but not the same.
Okay, we're just going to quickly see if we can pull up this little video here for you. Here we go.
I think Norman Rockwell made a Grey's Anatomy cliffhanger, a tiny town, a heart attack, and all the people who streamed out to keep pumping and pumping and pumping. Dan Harris explains.
Hopefully this is working. If it's not, please let Steph know.
In tiny, remote Goodhue, Minnesota, where they don't even have a traffic light. Then something unusual, a 911 call.
911, what's the emergency? We're at Don Foods in Goodhue. The guy just fell.
A man named Howard Snitzer had hit the ground with a massive heart attack. The only customer in the grocery store at the time, Candace Kane, started first aid. And then from across the street, Roy and Al Lodemeyer of Roy and Al's Auto Service rushed over.
He was in trouble.
They began taking turns performing CPR, switching at the point of pure exhaustion without missing a beat. And as news spread, their number grew. A pair of IBM employees handing it off to a plumber, who handed it off to a carpenter, who handed it off to a county employee. In total, 24 pairs of hands.
We just lined up, and one guy had enough. Next guy jumped in.
Amazingly, none of these people had any idea who Howard Snitzer was. The paramedics arrived to an astonishing scene.
It was unbelievable. There were probably 20 in line waiting for their turn to do CPR.
This lasted for 96 minutes until Howard's pulse started, and then they transported him to the hospital.
We got 10 on board.
10 days later, he walked out of the Mayo Clinic miraculously healthy and incredibly grateful.
I happen to have a king-size heart attack in the right place at the right time. And these guys would not give up.
The other night, a reunion between all those people who wouldn't give up.
I've been waiting for this moment.
And this man who is now no longer a stranger. Dan Harris, ABC News.
Okay, so back to our webinar there. How'd you like that, Matt?
Kudos to Candace Kane for jumping on that chest early.
Yes, and good.
Having a name like Candace Kane.
And Harold. So the reason we showed that video, well, it was a great outcome, especially at this time of year. Apparently, it was reported that EndTidal carbon dioxide monitoring was utilized throughout this call when the paramedics arrived, and that he consistently maintained an EndTidal CO2 monitoring of 28 to 36, so that they used it for effective chest compressions, not that we would line up 20 paramedics in a row, but just as an example of one way it was used and with a good outcome.
And here's someone who is in refractory ventricular fibrillation, so you know, the treatment for that, chest compressions and shocking the patient.
Okay, in terms of cardiac arrest, it can assist us with evaluating, again, how our cardiac output is occurring during CPR, but also if there's other things that may possibly be going on in the call. So let's say that we had 24 rescuers and we had adequate CPR occurring the entire time during a cardiac arrest. If we saw a declining EndTidal CO2 that was consistently declining despite the fact that we're providing adequate CPR, there might be other causes of a cardiac arrest or other things that are occurring.
And so it's important to remember that there's three things that capnography depends on. The first being ventilation. So how effectively is CO2 being delivered to the lungs themselves or the pulmonary system? The second thing is perfusion. So how effectively is the carbon dioxide being transported through the vascular system? So how well is that heart functioning? And then of course metabolism. How effectively is CO2 being metabolized by the cells themselves? So, you know, for prolonged periods of downtime, the cells are going to stop working, they're going to stop producing CO2, so you're going to have a low EndTidal CO2 reading. So when you have multiple things going on, capnography is not as clean as when you just got one single thing going on. And as we know from our patient populations, the majority of these patients have multiple issues occurring. So again, that good, clean capnography reading and its sole use to diagnose something is why we can't use it, because there's so many variables that do occur. One question that has come in is, what would you see in the waveform of someone suffering from pulmonary embolism? So a patient has pulmonary embolus, I hook up the capnography to them, what kind of waveform am I going to see? And again, if this is just a pure issue of pulmonary embolism, nothing else going on with the patient, everyone's going to be a little bit different depending on the degree of the pulmonary embolism we're talking about. But this is an issue with the pump. So the pump, the heart is trying to pump against this large blood clot sitting in the pulmonary vasculature. So it's not going to be able to deliver that CO2 to the lungs to get them to the alveoli to expire it. So with a pulmonary embolism, you know, the waveform you would see would be typically pure pulmonary embolism. It would typically look like a normal tracing, except you'd have a lower CO2. Again, no one's going to ever diagnose a pulmonary embolism just based on capnography alone. There's going to be multiple things going on, so it's just a very small piece in that puzzle.
Good, thanks, Matt. So in that case then, let's look at EndTidal CO2 monitoring in spontaneously breathing patients and how we can apply that. So for an example, we could apply EndTidal CO2 monitoring device such as the one that looks similar to the nasal cannula in a hypo or hyperventilation patient. So causes of hyperventilation could be anything from anxiety to the pulmonary embolism that we were just speaking about. And in that case, the EndTidal CO2 would be decreasing because of the hyperventilation. So hypoventilation could be caused by, say, an altered mental status, and we discussed an overdose earlier, so that would be one of the causes. A stroke, a tiring CHF patient could be that patient. So they're breathing slower, and we're going to see an increase in their carbon dioxide production, and thus those very high readings. So in the case of the bottom one, the number on your screen may be above 58, maybe up to 60. Let's keep in mind that a patient who has a small tidal volume can hypoventilate despite the fact that they have a normal respiratory rate. So they may be breathing at a rate of, say, 18, but because they're taking in very low tidal volumes, they could be actually hypoventilating. So EndTidal CO2 monitoring is a way to recognize that. In these patients, we would want to utilize this in terms of looking at the ongoing trends. So pay attention to what's occurring with the EndTidal over time. If we have the case of a hyperventilation patient where EndTidal is low, our goal would be to slow down their breathing rate and hopefully achieve higher levels of an EndTidal between 35 and 45. The same could be said in when we're ventilating a patient, for example, if we were with a BVF.
I agree 100% there. Again, capnography is dynamic. It's going to change over time, even within the same disease process, depending on what's going on. So try not to get too hung up in it. Just use it as that piece of the puzzle and what's going on with your patient.
Good. In the bottom example, we have this could be placed on a patient who's post-seizure, post-ictal. So you can see, I can look at that and say, well, they're not breathing very quickly and their EndTidal is high, so maybe we want to ventilate that patient. It's not quite adequate at that point as a piece of the puzzle of ongoing proper patient care. Absolutely.
So just based on the history alone, the patient's had a seizure. After you get there, seizures subside, and your post-ictal patients tend to hypoventilate just on the process itself, and you look at the patient and you're not seeing that chest rising and falling like it should. You hook up your capnography and sure enough that goes exactly what you kind of already know is going on with this patient. So just a piece of the puzzle.
So just quickly looking at a case study, this is a patient with an altered level of consciousness with a normal blood sugar reading. She's suspected of an opiate overdose, and if we look at her capnogram, we can see that her EndTidal is slowly decreasing, and then the trend that it's slowly decreasing as well. So we might say that this person is prone to experiencing respiratory failure or respiratory arrest. That's just one example of how you would use a trend over time to manage or evaluate a patient's ventilation status.
So another question has come in and is asking, what would the EndTidal CO2 look like for a silent chest? And a difficult question to answer because there's all different reasons for a silent chest. So this is a good reason as to why you can't say, this is what it's going to look like in this case. You've got to know what's going on with the patient, what the history, what the physical is, what other vitals are to kind of put it in context to your patient. So for the silent chest, a silent chest in someone who is in cardiac arrest, well, you would expect that the CO2 is going to be low because the heart's not pumping properly, not delivering that CO2 to the pulmonary system, they're not breathing. So they're not getting rid of any CO2. The cells have stopped working. They're not producing CO2. So, with that kind of silent chest, depending on what part of the arrest, if it's early on versus late, it all depends on the patient. So again, these kind of questions, there's not one single answer. The silent chest for an asthmatic, again, it depends where they are in the cycle. If this is, a silent chest early on, they've been hyperventilating, trying to, increasing the respiratory rate. You expect the EndTidal CO2 to be low. But later on in that course, when they're tiring out and you have a silent chest because of bronchoconstriction, you expect the EndTidal CO2 to be high. So again, you have to put your capnography in context with your patient.
Well, that's excellent timing for the question, because our next slide is about asthma, COPD, EndTidal CO2 retainers, people with increased expiratory times. If you notice at the bottom tracings, this is an asthmatic patient. The top waveform is characteristic of a typical, again, it's not every single patient, of a typical asthmatic patient. And that they call this kind of the shark fin capnogram. In that you can see the prolonged expiratory phase and the increased EndTidal CO2 because their retainers and they're blowing up.
They're having difficulties expiring because of bronchospasm. So you expect, they're having that prolonged expiratory phase, which is the hallmark of an asthma exacerbation or a COPD exacerbation, which is why you're getting that very long plateau. And typically, depending, a COPDer is going to tends to run a bit higher CO2 on a good day, which is why they're going to have a higher level of expired CO2 being measured.
So the medics in this case arrived at 10:35 on the top and the second capnogram, and the patient was struggling. Respiratory rate was decreasing, and they started their treatment, which was salbutamol, which kind of started increasing their EndTidal CO2, and then over time and after the second treatment, the patient was successfully treated and decreased the bronchoconstriction. You can see that their capnogram went back to normal. So that's just one way of using the trend. You can actually assess the effectiveness of your treatment by looking at the monitor. Of course, we're always going to examine our patients, but this is one application of EndTidal CO2 that is applicable to our setting.
Absolutely. I mean, this is some real-time quantitative feedback for the medics. Again, as Christine said, you're going to be taking this. You're going to be taking this in the clinical context of your patient. So, your patient's looking better. They're saying they're feeling better. You listen to their chest. They're less tight, less wheezy. You look at your capnography, and oh yeah, when we first got there, it was these prolonged expiratory waveforms. Now they're shortened up. Less expiratory phase based on your clinical judgment, and you lose that shark fin pattern because of the decrease in bronchospasm from your treatment. So, I keep saying this, and you're probably getting tired of saying it, it's just a piece of the puzzle in your clinical exam, or sorry, in helping you figure out what's going on with the patient, but also how your treatments are going.
And difficult for us as well with one webinar alone to provide you with all of the information surrounding the applications of EndTidal, but maybe possibly worth a second webinar if we get enough interest. So keep your questions coming in as well. So we should quickly just review some of the limitations we did talk about throughout the webinar that Matt had mentioned. EndTidal CO2 monitoring is most effective when assessing a pure ventilation or perfusion or metabolic problem. So for example, it's not going to be of great value even if you assess the trends in a patient suffering that we examine and assume it's acute pulmonary edema. However, this is from an acute myocardial infarction, which has caused decrease in cardiac output as well. So that's not going to be effective.
Absolutely. So there you have both a pump problem, so an issue with perfusion, and also a ventilation problem because of pulmonary edema. So that's when it becomes very tricky to discern what's going on from your capnography alone. So in pure instances of one issue alone going on, much more helpful than those other mixed ventilation perfusion issues, such as in CHF with an MI.
We may have difficulty with patients who are breathing through their mouths, especially, obviously, if we're using the nasal cannula type tongue, although most of those devices have something that's intended to scoop the carbon dioxide exhalation, but that's just one of the limitations. The sensitivity for esophageal intubation or placement is uncertain. However, it is very specific to tracheal intubation. So that means that you could get some EndTidal readout if you are in the esophagus, but you definitely won't get one. You will get one if you're in the trachea.
You will get one if you're in the trachea. With the esophagus, yes, you can get some EndTidal CO2 reading, but over time, if you're using capnography in the intubated patient, what you will see is diminishing CO2 output because you are in the esophagus. So that initial first few reads, you may get some CO2, but each kind of waveform is going to be a lower and lower amount of CO2 occurring until eventually zero, which tells you you're in the esophagus.
So how that becomes applicable to us is look more than once. Don't just look at the screen and go, oh, I've got an EndTidal reading, I must be in the trachea. Just make sure that you take a couple of glances over a couple of minutes and ensure that you have an EndTidal, sustained EndTidal CO2 reading.
Absolutely part of your monitoring, because we all know, tubes are finicky and can become dislodged, so especially on the transport. So it's part of your monitoring. If you're noticing your EndTidal CO2 is you're getting a flat waveform, then that should, again, looking at your patient, what else is going on? Is this, they have a pulse, okay, well, this is an issue with the tube, and maybe the tube may have slipped and is now no longer in the trachea.
So it should be used with intermediate airways such as the King LT. However, there is a lack of evidence, but it still should be used and should be able to produce an EndTidal CO2 capnogram and level for you. The summary of the key points, absolutely, tracheal placement should be confirmed using an EndTidal CO2, absolutely, and should be monitored as well. We can use EndTidal CO2 monitoring to ensure adequate CPR, back to making sure that our rescuers aren't tiring, and could be used to assist with ROSC and loss of spontaneous circulation, as Matt has reiterated a couple of different times. It's a piece of the puzzle and something interesting we can add into our practice, and especially with the ongoing research and changes in care. Hopefully it evolves.
Absolutely. I think those are the biggest, bang for your buck uses of capnography at this point in its infancy in the pre-hospital setting. So I think those are where you're going to get your most use from it. Absolutely.
So we don't have very many questions. I was hoping we'd have a couple of more. So that means we either really did a really great job of explaining it, or...
Of course, if questions come to you, then by all means get in contact with one of the educators and we'll be able to answer your questions.
So if anyone does have a question that they'd like to ask live, go ahead and click on the hand icon on your toolbar. I'll be able to see that, and if I do see that, I can unmute you and you can ask questions live. So I'll give you a couple seconds to do that if anyone does want to ask a question live. I'll keep an eye on that. I did get a couple comments come through asking for a Capnography Part 2 webinar, so we will look into that definitely and see what we could potentially put together.
If anyone wants to volunteer to help out, we'd be happy to get some assistance.
Absolutely.
That would be great.
Get an extra CME point for asking a question live in a webinar, because I don't think anyone ever has on stuff.
No, you're right. I do see hands every once in a while, but they're usually errors. So I'm not seeing anything come through. Thanks again to Christine and Matt for a great presentation, and thank you to everyone who did attend. I think this is our last webinar for 2014, so wishing everyone a very Merry Christmas, Happy Holidays, and keep an eye on your email for our next webinars coming in 2015. Thanks a lot, guys. Have a great day.
Thank you, Scott.